All right, so I think we'll get started. Welcome to Mayo Clinic Health System. My name is Mike Raymaker. I'm an athletic trainer, physical therapist, and strength and conditioning specialist here in Rehabilitation Services. And tonight we're going to talk about preventing anterior cruciate ligament injuries in both males and females through jump training. Now, we've received a lot of calls about this program. There's a lot of questions about it, so I'm hoping to clear up a lot of those questions that you might have regarding preventing ACL injuries, the anterior cruciate ligament injury, with jump training. We have 4 objectives tonight. The first one is to report the prevalence of these injuries across the country, because they're quite numerous. The second one, we want to describe briefly the anatomy, the biomechanics, and how the ACL is typically injured. Then we want to talk about associated injuries that occur with the anterior cruciate ligament injury and the prognosis. We'll talk about treatment as well. But then we want to get in to this topic of jump training, which is a research-based approach to neuromuscular training to try to decrease the number of ACL injuries in both males and females. It's estimated that there's about 250,000 to 300,000 ACL injuries across the country each year at a cost of about $17,000 to $25,000 for treatment, typically surgical intervention followed by rehabilitation. Now, the studies that are listed underneath that comment indicate the prevalence of ACL tears in females to males. So if you follow, in '85 they said it was approximately 4 to 1, 6 to 1, volleyball players 4 to 1, female volleyball players, female basketball players 8 to 1, soccer 6 to 1, military training 10 to 1, and then the United States Military Academy and other military training 3 to 1. So it occurs much more in females than it does in males, but we need to be able to protect both populations in an athletic setting. All right. Before I start talking about the anatomy, a couple things one big concept to understand, and that's joint stability. Any joint has 3 elements that makes it stable. 1, bony arrangement, bony fit, how one joint fits, how one bone fits into the next. The second element are what we call passive constraints. Things like ligaments, capsules, cartilage, those types of things. The third element is more dynamic, and that's muscle. Muscle has the ability to lengthen and shorten and absorb and dissipate force, try to minimize the forces acting across the joint. So as we talk about the knee, keep those 3 things in mind. Because this is our knee, here's our femur, our thigh bone. Here's our patella, our kneecap, and our tibia. Notice, let's take a look at what we call joint congruency first. If you were to strip all these passive constraints away, you would have this femur with these rounded ends on them that they call condyles. There's one here, this is on the medial side or the inside. This is the lateral one here. You take off these menisci, you have a flat tibial surface. So you have 2 rounded ends of the femur sitting on a flat surface. Not real joint congruency. I think you could all agree with that. You have a round surface sitting on a flat surface. All right? So now the knee relies heavily on these passive constraints. These guys are like, these ligaments anyway, they're like guide wires. They're going to take some tension until that force imposed on them is so significant that they snap, okay? So we have our medial collateral ligament here, that's on the inside. Lateral collateral, that means it's on the outside. Here's the star of the show, the anterior cruciate ligament right here. It's cruciate because the two ligaments cross. Cruciate means cross. So you have your anterior cruciate here that's in the front, and you have your posterior cruciate in the back, so you get your cross. Again, we'll get a little bit more specific about the ACL here in a second, but they all provide a restraining force. Then you have these joint cartilages here. Those are called menisci, meniscus singular. These are narrow on the inside, high on the outside, and they really come in handy because when every one of you get up out of that chair tonight, your femur is going to roll, if this is your femur, bent, sitting on top of your tibia. That femur is going to roll, it's going to slide, and it's going to rotate. What those menisci do, because they're low on the inside and high on the outside, they decelerate all that rolling, gliding, and sliding. So they're helping these ligaments hold these bones together here, here, and in the middle by decelerating all that motion that occurs at the joint. All right? Just to finish up the anatomy, this right here is what we call articular cartilage. That's different than this. Two different animals. This protects the end of the bone. It's like Teflon. So now the bones can glide across one another like a rock over a calm stream. Okay? That's really important. It's this structure here that's damaged with osteoarthritis. That's the part that decays over time. Rather than being hard and smooth, it becomes soft and flaky. And the interaction between the two bones becomes more inconsistent, more difficult. Okay? Now, the last thing that you cannot see on here is a thing called the capsule. The capsule, these ligaments, you need to think of these ligaments on the outside here, they're kind of thickenings of the capsule. The capsule attaches around the tibia and around the femur, and then these ligaments are reinforcements of the capsule. So all of those structures that I just mentioned are passive constraints. Okay? The one big dynamic restraint that we haven't mentioned is the musculature of the lower leg. And we're not going to go over all of those muscles, but we'll talk about them in a little bit. So, here's our biomechanics, a little bit of anatomy. If we go back, this anterior cruciate ligament starts in the front of the tibia, so it's called anterior. It's going upward, backwards, and it's going over here towards this lateral femoral condyle. So it's crossing the joint like that. Its primary job is to keep your lower leg, your tibia, from going forward in the event that somebody hits your knee or when your foot lands on the ground. 85% of its responsibility is that. Keep the tibia from going forward. That's an important point to remember. However, it also, that ligament, if you were to get hit from the side, it keeps the bones, helps you keep the bones together. If you get a blow from the outside, from the inside, or if you twist your knee to the inside or to the outside, or if your knee goes too far backwards, we call it hyperextension. So it has a huge responsibility. In more practical terms, it means it has a lot of ways to get injured. Okay? All right, the mechanism of injury. 70 to 83% of the time, ACL injuries occur from a non-contact valgus load, okay? Which we call a non-contact injury. This is a valgus load. My foot is fixed. My knee travels to the inside of my foot, and there's rotation there. There's a lot of different types of motions there, and you will load that anterior cruciate ligament. You can see here two rather famous ones. This is Rebecca Lobo, And we all know RG3 last year during the playoffs. Now, I'm going to show you two injuries, two film clips of a classic landing from a jump, non-contact injury. If you're a little squeamish, you might not want to watch, okay? Whoops.
We have to click on the video on the computer, Mike. Use the mouse to click on the video itself.
Gotcha. Foot hits the ground, knee goes inside the foot. That is your classic non-contact landing from a jump anterior cruciate ligament injury. Now, those of you that play basketball in here, and any court sport for that matter, know what a jump stop is. So you don't have to land from any high elevation to injure your ACL. She'll get down on the other end of the floor and make a jump stop. Watch her left knee. All right. So, what all can happen when you injure your knee like that? Well, you know, we're always concerned about the anterior cruciate. But as you start injuring ligaments in the joint, the total pathology can be potentially much more significant. So you could, in addition to tearing your ACL, that medial collateral ligament that's on the inside of your knee can also be torn. Your medial meniscus, which attaches to that medial collateral ligament, can be torn. Typically, there's a little subluxation to the twist of the femur, and you get a bony bruise on your tibia. And in extreme cases, you can also tear your posterior cruciate ligament. And if you tear both, that's pretty significant. Now, one of the other things that we should point out that happens a little less often, but it's still significant, is this articular cartilage tear. Remember I said that joint cartilage, over time, in some people, you'll get osteoarthritis because it degrades. Well, sometimes during these mechanisms of injury, you can almost get an acute osteoarthritis because you'll tear through that articular cartilage to the point where you expose the bone to the joint. And that's not good because those two environments do not interact. So you have to have a microfracture to repair that. That's another surgical procedure. The last thing is that in youth and adolescents that have not physically matured yet and their growth plates are still open, it's very rare, but you can also have a growth plate injury as well. So there's a lot of things that concern us here in orthopedics and sports medicine about ACL injuries. The result is what we call an instability. So you have this incongruous joint that relies heavily on passive constraints, and now you've lost them. You've lost the ACL, or maybe you lost the medial collateral ligament, or you tore that medial meniscus, so it has difficulty slowing down that femur as it rolls, glides, and slides. All right? That's what we call an instability. Now, in a situation where someone is speaking with a physician about treatment options, if you're involved in athletics, where you're involved in a lot of cutting, pivoting, twisting, a lot of starts and stops, and you're going to continue that after this injury, there really is no other way than to go through a surgical treatment. Even if you're really physically active, maybe you're in construction, where you're walking on a lot of uneven surfaces. it's recommended that you have your ACL reconstructed, treated surgically. We'll get to that in a second. But because you lose those passive constraints, now you have an instability. So your treatment, I should say one other thing. Let's say you're sedentary. You work behind a desk most of the time, and you don't really venture out and get physically active. There is about 25% of the population who, if they continue with therapeutic exercise, rehabilitation, whatever you want to call it, and brace the knee, they can go for a long time without having episodes of twisting and pivoting and tearing additional structures. But it's only if you're pretty sedentary. All right, so treatment-wise, the gold standard, at least at this point, is to take out the patellar tendon of the same knee with a bone plug off the patella and a bone plug off the tibia, and reinsert it going anterior, up, back, and posterior to its normal footprint and the normal anterior footprint. And so you're taking the middle of your patellar tendon, which is right here. They're taking the middle third of that out, and they're putting it right there. And then you come and see people like me to do all this. 6 to 7 months of rehab. It's a lot of fun. Now, in rehab, what we try to do is the surgeon restores the anatomy. Our job is to restore the dynamic stability. That's the muscle work. So what we do is say, the physician gives us the guidelines for how long before you can do this, how long before you can do that, and then we do the rest. All right. So across the country, how have we done? Well, there is a recent systematic review, which is a pretty high-level study. They would call it level 2, just one step below the best type of research out there, where they reviewed 48 studies with over 5,000 cases of ACL reconstruction over 41.5 months. And these are all listed outcomes. Now, these bottom two, you look at these and you say, well, near normal function according to impairment-based outcomes. Impairment-based outcome means we check to see if the ligament's secure, we test some strength, we test some range of motion, that kind of stuff, all right? Then down here, these were activity-based surveys. There's international surveys that you can fill out, and it's the patient that's filling it out. But notice here that it says 85 to 90% return to normal. Now look at these three numbers. 82% return to some kinds of sports participation. Doesn't say if they return to their previous level of their previous sport. 63% return to their pre-injury level. Now, just a side note, Jim Andrews, and I don't know if you folks involved in baseball and softball probably know of Dr. Jim Andrews, and if you follow the Redskins, you know Dr. Jim Andrews is their team physician, and he really got started in baseball. About 7 years ago, I was down at his conference, and he said that there was a 250% increase in ulnar collateral ligament reconstructions across the country. That's reconstructing this ligament here in your elbow in a thrower. And they went through all the different explanations. And then he said, there's part of him that believes that there's a certain population out there that believes, if I tear my ulnar collateral ligament, big deal. I'll be as good as new afterwards. Then you look at these numbers. 63% do not return to their pre-injury level, and 44% it takes 3.5 years to return to their pre-injury level. So it's not a done deal. There's a lot of factors that go into determining how fast somebody can return, and a lot of those associated injuries play a large part of that. Now that all the doom and gloom is over, there is hope. In 1999, Tim Hewitt and the Cincinnati Sports Medicine Group did a study, where they took female high school volleyball, basketball, and soccer athletes, split that group into two parts. A trained group where they were going to get specific training that we call jump training, a group that got no training whatsoever, and a group of high school men, or I should say boys, high school basketball, soccer athletes. Okay? So the one group gets strength and conditioning, flexibility, agility training, and jump training. The first group of females, the trained group. The second group does not get the jump training, gets everything else. The guys get the same training, but no jump training, just like the untrained females, okay? Now, when you see this up here, this athlete exposure hour, one athlete exposure hour is one athlete participating in one practice in a season. That would be one athlete exposure hour, okay? And it would go up as your practices and competitions go up. So in the untrained females, you had 0.43 injuries during that 1,000 hours. Notice this, dropped in the trained female athletes. And notice this, pretty similar to the males as a result of that jump training. Then your untrained females had almost 4 times higher risk of an ACL tear without jump training. And you remember those numbers that I showed you in the original research years ago? Pretty close. And then finally, and then they had almost 5 times higher than the male athletes, which is consistent. And then lastly, the incidence of injury in trained female athletes was not significantly different from that in the untrained male. So first you say, good, right? But what are the differences? Why are females more susceptible, apparently, to ACL injuries than are males? There's a ton of studies that have tried to establish the anterior cruciate ligament is probably the most researched ligament in history. Every month when our group does a literature reviews so we can write up our protocols, there are more studies on the anterior cruciate ligament than any other ligament. But still, 15, 20 years ago, one of our surgeons who was being trained in Vail, Colorado, said, you know, this is going to be great. There's all this research going on. We're going to have this thing nailed by the time I get out there and practice. And he just said that at our last Sports Medicine Journal Club. So here we are 15, 20 years later, still working on this issue. But we've got some good information here that I'd like to share with you. The first one is there are certain things that we cannot change. We cannot change our anatomy. We could go on and talk about notch stenosis and all this other kind of stuff. We can't change it. We are who we are. Second thing is genetics determines a lot of our development. And there was a big thing about hormonal influences, you know, in females. There's been no connection between the two, other than the fact that there are receptors on the ACL for some hormones. But there's been no direct relationship between the two. But the one that we can affect is this right here, neuromuscular training. These are the modifiable risk factors that research has identified for us to use to help decrease ACL injuries, especially in females. This first one is called ligament dominance. What they have shown is females are weaker in the legs, and therefore when they land, they're not strong enough or powerful enough, which is a difference, and I'll explain that in a second, when the foot hits the ground to manage that side-to-side difference in the knee that you saw in Rebecca Lobo when she hit the ground. Now, what's strength? For you people in physical science out there, strength is force times distance. You take 300 pounds on a bar, me and another guy, I go up and it takes me a minute, I grunt it out, I get 1 minute, I'm 300 pounds strong, all right? Force times distance. However, if I have a guy over here and he takes the 300 pounds and takes up in half a second, that is power. Force times distance divided by time. He can do it faster. And why do coaches like power? Because you can do the same work but faster. Okay? The muscles fire faster and you can get your work done as an athlete and you can overpower somebody. So what you want is a strong musculature in the limb and in the trunk, as you'll find out, but you want it to be powerful as well so it can contract quickly to manage the forces acting across the knee. All right? Quadriceps dominance. Quadriceps are the muscles on the front of your thigh. There's 4 of them. Quad means 4. They come off the thigh, one comes off the hip. They all come down and they attach right here in front of your tibia. Yeah, big deal. What do? They do this. The reason why quadricep dominance is an important issue, the job of the anterior cruciate ligament is to keep the tibia from going forward. Well, when the quadriceps pull on the lower leg bone, it pulls the tibia forward. So it's almost assisting in developing the anterior cruciate ligament injury. So females, we spend a lot of time working the hamstrings on the back side of the thigh because they tie into the back side of the tibia, and when they shorten, they pull the tibia backwards. Okay, so quadricep dominance is another modifiable risk factor. Leg dominance. It's been shown that there some in a large population of females have one dominant leg over the other. In other words, muscular strength and power is weaker on one side. Now you combine leg dominance with fatigue, you got an issue. If you're a jumper, if you're involved in a sport where you have to land from a jump. Now, think about this. Everybody knows what a jump is or a hop and you land. But when you are sprinting, are you landing from a jump? Are you landing from an elevation? Because if you're sprinting, there's a flight phase. Both feet are off the ground at once. We've seen plenty of people in here that were just sprinting. They were playing flag football. They were playing at the indoor facility. And they were just running down the field and they tore their ACL. Okay? Trunk dominance. If there are large swings in the trunk, the time that you hit the ground, you can accentuate the forces on the knee. So, my foot is fixed. My knee goes to the inside, valgus loading. And if my trunk goes this way at the same time, I am loading this injury mechanism with my trunk. So, those are all your modifiable risk factors. And so now we have to recognize them and then get you into the right program. So here we use Cincinnati Sports Metrics drop jump video analysis, and I'll show you a little bit of that here in a second. But that gives us objective numbers. We can actually, there's this thing called digitizing, where if you were to come in, we would put little dots on your hips, on your knees, on your ankles, and what we want to do is measure what happens to your knees when you gather to take off and then when you hit the ground. Okay? And you'll see that in the video. We also use the functional movement screen and a lot of these and a couple of other screening systems to help us identify athletes that are at risk. In other words, that have those issues with their those modifiable risk factors. So here is a drop jump video from Cincinnati Sports Metrics. Here's the dot I was telling you about. See that? One on each hip. At the knee, and you can barely see the one at the ankle and there. When you watch this video, I want you to watch the knees. Slow motion, the knees gather, and they gather again. That's what we want to try to prevent. Now, when we do an analysis, you get a report that looks like this. Now, this is not the same athlete that you saw just in the video. But all these lines, this is the digitizing. This tells us the likelihood that when she hits the ground and when she gathers to take off, what her knees are doing. This number right here is the one that we're most concerned with. This number right here should be 60% or greater. If this number is 60% or greater, they say you have a low risk for an ACL tear. But notice this. She's got a long way to go. All right? Now, here's the first female that we saw in slow motion after 6 weeks of jump training. Notice the separation both at the gather as well as takeoff and landing. Now, you would think, well, anybody can do that. You would be surprised that, now there are 6 of us here in Rehabilitation Services are all certified to do Cincinnati Sports Metrics jump training. When you tell somebody that they're doing that, no, I'm not. Let's look at the film. And their eyes just get. So, and research has shown that you got to give these clients the right verbal cues at the right time to get them to learn how to land softly with both feet underground or both feet underneath their center of gravity, balanced, and to catch themselves as they hit the ground. Well, when you're all done, we do at the beginning of our session, we do a pre-screening, digitizing, and we do a post so that you can see the improvement. Now, this was the woman, or this was the gal that you saw on this report previously. And after 6 weeks, that number is now 75, 73, and 68. She has reduced her risk. That's why jump training is important, right there. All right? It reduces, it helps us identify those modifiable risk factors, and it helps us modify the risk factors to decrease that incidence of injury. So, this is a research-based program. It's called Cincinnati Sports Metrics. It's a 6-week program. It consists of flexibility or stretching, and then traditional strength training, squat, leg press, etc. And you'd be surprised. I would say of the athletes that I see that come through the clinic, you guys know how to squat? Oh, sure, I know how to squat. And then you see this. Big arch in their back, lost neutral spine, loading their vertebrae with that weight, and there's a lot of correction that needs to go on there. But then the jump training consists of 3 different phases: a technique phase, a fundamentals phase, and a performance phase. Each phase is 2 weeks long with a certain series of jumps that you perform for time, typically. Then there's also an agility program. We provide that service in a lot of different ways through Sports Enhancement. We have an individual program that's $250. It's an out-of-pocket service. But it's 7 sessions. You get a pre and a post test, and then all the training in between. And it's much like a physical therapy program, We teach you how to do it so you can do it yourself. If you could learn this, you know, like when you're a middle school athlete and carry it through your athletic career, it'd be well worth the time. We also offer it in a small group package, like groups of, you know, 5 or 6. That costs us $175 a piece. But with this year, we also provided a high school package. We piloted a program. We did it out at Fall Creek High School, where we negotiated a flat fee for the number of athletes that wanted to participate. Because what we'd really like to see is a lot of schools are getting into the summer conditioning programs or off-season conditioning programs, usually supervised by a coach or a coach of that particular squad. We would like to see them dovetail this jump training program into their typical weight room activities so everybody gets trained in jump training. And we would like to see the incidence of ACL tears go down. So that's kind of our goal, and that's why we've been doing this for a while. And like I said at the beginning, I get a lot of phone calls, you know, what is this jump training business and why should I do it? I hope I answered some of those questions here tonight, because we see too many ACL injuries in our clinic. If you want to review this information later, you can go to our website, because it will be probably downloaded in about a week or so. If you want to get a hold of me or set up a time for an individual or group session, you can contact this number right here, 838-6190. Rehabilitation Services is in the Middlefort Clinic Building East, which is on that side of the building downstairs. Oh, I left out a slide. Anyway, now what I'd like to do is I'm going to roll a video of what they call the technique phase, so you can actually see what at least phase 1 looks like. While we're doing that, if you have any questions, please raise your hand. I'd like to answer as many questions as I can. To do that, however, I'm going to have to take my mic off so they can turn that down a little bit. So, Jamie, if you want to roll that video, and be glad to take any of your questions.